Okay, how many, shall I wait for some time, or this is the number of people that we have got? Hmm? I don't think they will come, no? Okay. So, give me a second. Second. Okay. Oh, can I start?
Yes.
Okay. Right. So today's topic is about normal pregnancy, diagnosis, and physiological and anatomical changes. Okay. So this is basically an introductory lecture. We are not going to go into depth on this subject, but I will give you an outline. Okay. So you all know, you all aware that there are the things, the sequence, or how the conception, human fertilization occurs. Okay, so ovary, releases an egg. Egg inside the human body has a lifespan about 20 to it's 12 to 24 hours only. Okay, so if the sexual intercourse occurs and the sperm reaches, sperm has male, the sperm has a lifespan about 4 to 5 days, okay, maximum. So inside the human body, it can live in the mucus plug, it can live up to 5 days. So it reaches, and the fertilization occurs in the end of the fallopian tube, and then once the the once it comes to the it through the endometrium, and implantation occurs around sixth or seventh day of your of the embryo embryo around seventh day embryo, or the stage of the embryo is closed, called blastocyst. It implants. Around that time, the patients, most of the patients are not aware that they are pregnant, and they may even experience a little bit of bleeding. We call it, uh, it's called implantation bleeding. Okay, so patients don't know, but around that time, they may experience a little bit of blood stain discharge. Sometimes they might take it, consider it as a pregnancy also. So it is called implantation bleeding. So that's why we don't normally rely on the last menstrual period alone, because it can be wrong. So we normally, when we date the pregnancy, we use the scan. When we do a scan, that's why scanning. That is one reason why we definitely have to scan them and correct the date, or correct the make sure that the expected dates that we calculate from the last menstrual period is correct. Okay, so after we calculate the date. Okay, so duration of this pregnancy is calculated to be around 280 days. So actual age, that is embryonic age, is 266 days, because when we calculate from the last menstrual period, we take about 2 weeks of that period also. From the last menstrual period, 14th day she ovulates, and then fertilization occurs. And then from that time onwards, we calculate extra 266 days. 14 days from the last period, 266 days, and total days are calculated, and it is totally 280 days. Okay, so from this only we calculate the expected date of delivery. Okay, so what happens is, sometimes when we do a dating scan around that time, okay, we do a dating scan. Give me a second, something happened to this computer, it got stuck. stuck there. Can you all hear?
Yes, sir. Yes, sir.
Yeah, some problem. The slide is not moving, so I have to find a solution. Okay, give me a second. Where is that? Okay, 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 okay. Now I got it. Okay, when we date the pregnancy, we measure a measurement called crown rump length. You can see this in this picture, right? You're seeing no crown rump length. Can you see that?
Yes, sir.
Yeah. So we measure to the bottom part and to the end of the head. So it is called crown rump length. If we measure this crown rump length, mostly the pregnancy is dated accurately, plus or minus. There is a kind of discrepancy of if there is a discrepancy of plus or minus 4 days, we take the scan date as an accurate one. For example, if the now this gives an expected date of delivery of December 25th of December, but when we calculate the last according to the last menstrual period, it measures uh, about 12th of December. There is a big gap, no? 12th of December to 25th of December. There is a discrepancy more than 4 days. So you go by the scan date. If the dates are almost within 4 day discrepancy, we take the LMP date. Okay, so that's how we date the pregnancy. This is before 13 weeks plus 5 days time. This is in the first trimester where we must do the dating. But after 13 weeks plus 6 days, when that period is over, when the first trimester is over, we call it in the first trimester, we date the pregnancy using crown rump length. After the first trimester, we use the measurement of head circumference. Okay. So we divide the pregnancy due to our kind of lot of things, body changes and pregnancy related changes. We divide the period of pregnancy into 3 trimesters. First 13 weeks plus 6 days, first trimester. From that period onwards, second trimester up to 28 weeks. After that, it is called third trimester. Okay. So we divide into trimester means 3 months. We divide into 3 months periods. Okay. So first trimester, second trimester, and third trimester. So up to 13 plus 6 days, we call it first trimester. Up to 27 weeks plus 6 days, we call it second trimester. From there onwards, we call it third trimester. There is something called viability. When we look at the pregnancy, there is something called viability. Viability is a term we use to describe the point beyond which the baby will be survivable. Baby will survive outside the world. This age is, according to WHO, it is 24 weeks. After 24 weeks, baby should be able to survive outside the world. In Sri Lanka, there is no consensus in the world, but we still take the age of 28 weeks. But, we were taking 28 weeks as a time of viability. Now, recently, we have, because of the advances of the technology, advances of the facilities we also now have taken 24 weeks as a time of viability. But in America, in other countries, they go up to 22 weeks. Okay. So that is the time called viability. There is something called term. Term kiyanne, if the pregnancy, the time of, the term means full term, full matured baby. So that is, baby is ready to come out. So 37 completed weeks to 42 completed weeks is the period called term. Okay, preterm means before anything, before 37 completed week is preterm. Post term කියන්නේ 42 completed weeks වලින් පස්සේ. There is something called post dates also. Post date කියන්නේ expected date of delivery is 40 weeks. Okay, any pregnancy you call it expected date of delivery is 40 weeks. So anything beyond 40 weeks is called post dates. So you should know the differences. Preterm, post term කියන්නේ 42 completed weeks. Post dates කියන්නේ 40 weeks, beyond 40 weeks. So, as I said, viability is the potential of the fetus to survive outside the uterus after birth, whether naturally or induced. Okay. So, term කියන්නේ 37 weeks to 42 completed weeks කියලා කියන්නේ. Okay. Then the term comes as gravida. Gravida කියන්නේ number of pregnancies, number of times the woman has been pregnant. Gravida. And parity කියන්නේ the pregnancies she had beyond 24 weeks. So, so one woman has been pregnant 5 times and she has only continued pregnancies, only 3 pregnancies. 2 pregnancies she has had delivered, and 3rd pregnancy she has crossed 34 weeks, and 2 miscarriages. Then you call it gravida 5, para 3. Okay. So likewise, we use the word called make a practice current. It's not easy to teach all these terms in one go. You have to, when you are going to the clinical setup, when you see the patients, when you read books, you should know. Gravidity is defined as the number of times that a woman has been pregnant. Parity is the number of times that the patient has given birth to a fetus beyond 24 weeks or more. So she should have delivered 3 babies. Deliver karla tino. All 3 babies have crossed 24 weeks, and she has 2 miscarriages. Then you call it G5 para 3. Okay. And pregnancy, with all these terminologies, pregnancy you diagnose, you do you detect a pregnancy when she is pregnant by doing a urine pregnancy test. That is more sensitive. Even if the woman has crossed past 2 days from her LMP, her urine HCG will be positive. Okay, so this is when this is how you do the test. When you put it in the urine, you see 2 lines. After that, you detect they are pregnant, and you can do urine blood. Sometimes in some settings they do pregnancy test by doing a blood test also, serum beta HCG. You don't necessarily have to do the tests, blood test to know, unless there is a need. Okay, we do serum beta HCG only when there is a necessity. But give me a second. Okay, so when a woman has conceived, they because of the hormonal changes, because of the rise in the beta HCG. Beta HCG is produced by the trophoblastic tissues. They get a lot of symptoms, mainly symptoms of nausea, vomiting, food aversion, sometimes later craving for food. All these are due to pregnancy hormones. And body, pregnancy hormone in the sense, it is not only beta HCG, progesterones, and human placental lactogen, and many more pregnancy hormones are secreted in the body, and they slowly rise. Because of these hormones, patients undergo a lot of physiological and anatomical changes. Knowing these changes are very, very, very important, because initially it can, when they present, you may have to, one thing is reassure the patients. Some patients are presenting with, some patients do come with exaggerated symptoms. Some patients do fall sick, or they become, those changes are not merely physiological, they go beyond physiology and they become pathological in certain situations. Sometimes the disease conditions can be masked by these pregnancy symptoms or pregnancy related changes. So you have to be very, very careful. Okay, so there are signs of pregnancy in the sense, this beta HCG, we now detect by using the urine test and followed by a scan. We do every pregnant woman usually get a urine test, and it is positive. Then we do a urine pregnancy. We do a scan to detect the pregnancy or diagnose the pregnancy, and we check the fetal heartbeat and tell them, or we tell them whether the pregnancy is within the uterus, or sometimes ectopic. We tell them that there is a pregnancy. Okay, so this is called scan for viability. This viability is different. We have to say there is a fetus, a live fetus inside the uterus. Then you tell them, you confirm with the blood test, you detect the pregnancy, and you confirm that there is an intrauterine pregnancy by doing a scan. This can be done as early as 6 weeks from the LMP, 6 weeks of period of amenorrhea. Okay, and there are signs and symptoms. Signs, you don't necessarily have to know. These signs were practiced in good old days. Those days they used to do Chadwick sign, so bluish discoloration of the cervix. It is called Chadwick sign. Godel's sign, when they do a bimanual examination, the isthmus area is very soft. So this is called Goodale's sign. Osiander's sign. Osiander's sign is when they do bimanual examination, again, they felt the uterine pulsations in the cervical isthmic area. So Osiander's sign. Hagar's sign, again, softness of the isthmic region. So all these signs, Chadwick's, Goodale's sign, Osiander's sign, Hagar sign, you should know by name. Okay, we don't use it anymore, but these were practiced in those days when the scan facilities were not there. But now we confirm by doing a transvaginal scan. If they present early, if they come around 6-7 weeks, we do a transvaginal scan. If they come later, after 7-8 weeks, we can do a ultrasound scan through the abdomen. So we do a scan and we locate the pregnancy, as in we say it is intrauterine. It is sometimes, if it is not in the uterine cavity, we have to look for the other places. It is called ectopic pregnancy. Sometimes there is no ectopic, no intrauterine pregnancy. You can't find out the location. It is called pregnancy of unknown location. Okay, and also that is very important. So when we do a dating scan, we look at these things: location, we look at whether this is single-term pregnancy or multiple pregnancies, and we measure the crown rump length and date the pregnancy. And also sometimes we look at the other abnormalities in the uterus also. Okay, so these pregnancies, although most of the pregnancies we expect them to have normal pregnancies, they can present with early complications also. There is something called threatened miscarriage. They can bleed, but still the baby can be alive. Baby's heartbeat is there, baby can have a small bleeding episodes. We call it threatened miscarriage. Sometimes baby's heartbeat may stop. It is called miscarriage. And sometimes there is a condition called molar pregnancy. Sometimes ectopic pregnancy. These are complications. So knowing that those complications are also important. And pregnancy symptoms, as I said before, physiologically, anatomically, they cause lots of changes in the body. Okay, you should know the physiological changes in the body. Okay, one is, they become amenorrheic. You all know that. But amenorrhea can be due to some other things also: stress, vigorous exercise, early menopause, endocrine problems. Those are the differential diagnoses. And significant breast changes, breast tissue changes. Breast tissue become enlarged and hypertrophied, and areola become pigmented, hyperpigmented. These breast changes you should know. And in the abdomen, they get a lot of stretch marks. Striae gravidarum linea nigra. There is a small line from the belly button to suprapubic region. That blackish line is called linea nigra. And stretch marks will appear, pinkish stretch marks, striae gravidarum. Okay, those are very important. And also, more than that, every system in the body, skin undergoes changes. Skin becomes hyperemic. A lot of blood supply to the skin occurs. And warm, they feel a little warm in the body. So those are the skin changes. and uh, and then all the body systems undergo changes. This is a very huge topic, so I am going to give you an outline. You may have to read. I will send you a kind of, through our department, I will send you a document, maybe I will send you a kind of full paper. You have to read and understand. Okay, physiological changes. Cardiovascular physiology is very important. That is the most important kind of system that changes in the body. Okay, blood volume, circulating blood volume increases. This is actually, these changes, physiological, anatomical changes do occur in order to facilitate the pregnancy and facilitate the delivery and to give the nourishment to the baby. Okay, so blood volume will increase. That circulating blood volume will increase by 40%. Although initially adult woman, the blood volume is about 7 liters, and this will increase by 40%. Okay, and cardiac output, heart will, cardiac output, the pumping ability of the heart, stroke volume, and the heart rate will naturally increase. These are due to hormonal changes. Resting heart rate will increase by 10 to 20%, and the heart rate will be high, and stroke volume will also be high. More than that, venous return will increase. There is a peripheral vasodilatation, and venous return will increase. Stroke volume will reduce, and blood pressure will also reduce. Okay, so cardiovascularly, I think stroke volume will increase. This is a wrong. In the slide, you will see stroke volume normally, heart rate and venous return will increase, and the stroke volume will increase, and cardiac output also will increase. Okay, and there is a peripheral drop in the total peripheral resistance. These changes are very important. You will get lots of MCQs, the simple MCQs. Cardiovascular system changes that occur in pregnancy. So, these statements will be given. You should know. There is no kind of working out things, but you should know what are the changes that usually occurs in a normal pregnant women. Okay. Any questions up to now? Are you all sleeping? Make a stroke volume will increase. Okay, stroke volume. I think make a stroke volume the SVR, total peripheral resistance when total systemic vascular resistance. Okay, this is a stroke volume will increase, peripheral resistance will drop, and blood pressure will also drop. Okay, and anatomically, cardiac heart becomes slightly biggish and displaces. The apex will displace to the left side, and there is a kind of a kind of cardio, if you take an X-ray, it will be different. And this will reflect in the ECG also. Okay. So cardiovascular changes, you should know there are lots of changes, but these are some of the key changes. Okay. So respiratory changes, I will quickly, I will skip this. Respiratory changes. Patient becomes, slightly dyspneic. Respiratory rate will increase. Hormone-induced tidal volume. Respiratory rate and respiratory rate increases. Tidal volume will increase by 40%. Because of this dyspnea, in the body, carbon dioxide saturation level will drop, and there will be a slightly alkaline environment in the body. Patients are always, they complain, I have a little bit of dyspnea. But if the exercise tolerance is becoming poor, if it is exaggerated, if it is more than the usual thing, you have to, it can be due to heart failure also. It can be due to respiratory infections, respiratory problems also. So usually there is a slightly reduction in the carbon dioxide level. If you do an arterial blood gas analysis, this will be reflected. But when the patients are sick, when the patients have respiratory problems, this will get worse. Okay. So, and also functional residual capacity of the lungs will increase, will reduce by when the diaphragm pushes. When the baby is becoming big, diaphragm will be pushed upwards. And this is a kind of graphical representation. Now see, in this one, in the non-pregnant as well as gravid woman's lung function test, residual volume will slightly. See, one thing that is not changed in this, these two situations are vital capacity. 3,200 vital capacity will not change, and inspiratory reserve volume will not change. Inspiratory capacity will increase in pregnancy. Inspiratory capacity. Expiratory, then functional residual capacity will reduce. You have to work it out. So tidal volume will increase. Tidal volume. Initially in normal adults, it is about 450. Tidal volume in pregnant woman is 600. Okay, so it is increasing. Then expiratory reserve volume in adults 700. Because increasing tidal volume, expiratory reserve volume becomes 550. Okay, so it also reduces the functional because of the diaphragm. Because of the diaphragm and increased tidal volume, functional residual capacity also is less. Okay, but this you need to work out here. I think you have to look into this. I can't explain simply. You should understand the basic physiology, or if you know this kind of normal lung capacities, normal lung function test interpretation only, you will understand. But whatever it is, you should know tidal volume increases, respiratory rate increases, carbon dioxide level will reduce, and there will be an alkaline environment in the pregnant woman's body. Okay. Okay. So we looked at cardiovascular system, and we looked at respiratory system and GI system. What happens is, because of these are happening due to progesterone hormones. When there is an progesterone hormones, gastric influx, reflux, gastric emptying will be limited, will be reduced, and tone will reduce. So there is a kind of intestinal motility, movements of the gut tube will also reduce. Sphincter tone will reduce, and there will be an stasis, especially when the woman has milky products, chocolate and caffeine. There will be a kind of increased tendency to have gastroesophageal reflux disease. So they are prone to get normally also. When they, with all these features, if their food habit is also not good, then they will start to have gastroesophageal reflux disease. They are prone to get that. And because of the gallbladder also, risk of cholesterol stone formation is also high. Okay. So GI features, and they get constipation easily. Okay, because of the less tone and less mobility and lower tone of the sphincters, they get uh, constipation. Okay. GO system, renal blood flow will increase, kidneys will become big, and kidneys will get lot of blood supply. GFR will increase up to by 50%. And because of the GFR, they tend to secrete lots of uh, creatinine, all this uh, sodiums, chloride, and all these will be low in adult women's body. Okay, when you do serum creatinine, concentration will be less because of the increased excretion. Okay, so GFR will increase, kidney size will increase, and kidneys blood flow will increase. Okay, so this will react when we do the interpretations, whenever we do blood tests, whenever we do urine tests, parameters will change. They are not according to when you do, the values in human adults. No, so this will slightly differ. There are different sets of uh, pregnancy values, pregnancy test results, and reference range will be very much different. So you have to always calculate according to the reference range of the pregnancy. Okay, so this actually, knowing pregnancy related values and pregnancy related body physiological and anatomical changes are very, very important. This case report we published in the BMC pregnancy. It's one of the leading journals in pregnancy. We had an interesting case. We had a patient. She presented with severe constipation in latter part of the pregnancy. She never told us that she is constipated. So after the delivery, she went home and she had a basically, because of the constipation, because of the fecal loading, she had obstructive uropathy. She had a condition called, it can happen in other patients, not in pregnant women, very common. Because of the fecal loading, she had ureters obstructed. She had acute kidney injury like features. So a GP had quickly evacuated the fecal loading by giving some enema. He emptied, or sometimes we do manual evacuation. When it happened, normally, occasionally, the kidney cells, kidney glomeruli can respond very faster than normal. When they had a block, when there was a malfunction, when the obstruction is relieved, they started to go into, they can have a phase called diuretic phase. She started to pass loads of urine after a quick emptying of the fecal load. It went up to a life-threatening condition. So we were not able to, because it's very difficult to look at the parameters. Normally we have to kind of maintain her volume, osmolarity. After delivery, this happened. After delivery, she started to pass urine like nearly 10 to 12 liters. This is called post-obstructive diuresis, and we used a lot of information. We had to, sodium levels, potassium, serum creatinine level, we were checking very frequently, and we had to use pregnancy related values to restore those. We can't normally calculate the need according to normal adults kind of reference ranges. So it was interesting to manage, and also it was a life-saving effort. So we published that and it got published. So likewise, knowledge of physiology and interpretation according to the pregnancy changes are very important when you manage patients. You should know the physiological changes thoroughly. And hemopoietic system also, in the blood there will be an increased volume of blood cells, and plasma volume will also increase, but increase of plasma volume is more than the red cells concentration, so there will be a hemodilution. Okay, and leukocyte count will increase. All this, if somebody asks why this is happening, we don't know, because these are some protective measures, or these are some favorable changes to accommodate baby and to look after the baby. And coagulation factors will also increase. These are happening because this is basically after delivery, women tend to bleed a lot. So these changes will help her to kind of reduce the loss. See, if the blood is diluted, she will lose only a little bit of red cell mass at the time of delivery. And procoagulant stage, they will quickly, when they have a, when the blood increases with clotting factors, easily the blood will clot and patients will not bleed quickly. So that's why coagulation factors will increase. So these changes will show up in the ESR also. That actually we don't know why ESR is high, but these changes in the body, in the kind of blood system, will automatically increase the ESR level. And there will, because of the hemodilution, there will be a slight reduction in the platelet count. This is physiological. But when the platelet count reduces by less than 100 million per milliliter, then it becomes a condition, pathological. We call it ITP, ITP in pregnancy. Okay, so you should know the changes. Hemoglobin concentration will reduce. There will be a hemodilution, and red cell mass will increase, blood volume will increase. All these things, you should know and correlate with the, with this knowledge. When you know this knowledge, when you interpret biochemical or hematological levels, or when you think about hematological changes, you have to, for example, coagulation factors increases. So, pregnancy is becoming a procoagulant. They are prone to get blood clots in the body. So whenever a pregnant woman with other risk factors get admitted to the ward, you should consider thromboprophylaxis. You know what is thromboprophylaxis? No? There are prophylactic measures to reduce the clot formation in the veins. If the clot forms in the veins, the condition is called deep vein thrombosis. They can even die. This condition, pregnant women are at risk of developing DVT and die. But this is not very common in our setup. But in Western countries, because of other risk factors, obesity, and lack of mobility, and all these things can lead to DVT frequently. A lot of women die. Whenever they go to hospitals, they have to assess it's called thromboembolism assessment, risk factor. Checklist ekak dala, they check, and then they consider giving various measures, low molecular weight heparin to thin the blood. They give as an injection, and we give stockings through low graduated pressure stockings to the legs to avoid or to prevent thromboembolism. All these are very important. This is because of we all do these things because of the knowledge that we have about the hematological changes in the pregnant women's body. Okay, so you should know each and every change that occurs in pregnant women. So recently we published, I'm just showing these things to kind of create an awareness. We had a patient who had COVID and COVID associated multi-system inflammatory syndrome. In pregnancy, apart from these hematological changes, pregnant women their body is also body shows a kind of poor response. Immune system also there is a malfunctioning. They get like they fall sick. Any infection they kind of, they it affects rapidly. Basically, there is a poor response of lymphocytes in the body. So this is basically to protect. Now baby is a foreign body, so to reduce the rejection, so immune system is compromised. That is a normal thing, but that also acts or behaves unfavorably when there is an infection. This woman had a multi-system inflammatory system syndrome. It's an adult type disease. A pregnant woman had it, and all the blood parameters were deranged, and she CRP was very high, and because of this, because of the exaggerated reaction uh, in the in the in the immune system, she went into kind of respiratory failure. She had a cardiomyopathy, myocarditis like symptoms, and she had high fever. All these were called COVID related multi-system inflammatory syndrome. And when it happens in pregnant women, we have to take into account of all the body changes and treat. We had to treat system wise. We had to look into kind of safety of her baby, and we had to give steroids and immunoglobulin to save that woman's life. But we had to use the physiological changes that occurs in the body, and hematological and biochemical parameters. All the inflammatory markers were calculated carefully according to the pregnancy status of the patient. So we used that, and we had to explain in the case report. We had to justify. We had to tell why we used, and we had to show the markers and all the parameters that were different from human adult bodies. And endocrine changes, hyperinsulinemia and fasting hypoglycemia occurs. And thyroid, in the thyroid system, vascularity, and there will be a mild hyperplasia that occurs. So there will be a small clinically detectable goiter in pregnant women. That is normal. Musculoskeletal system is very important. Because of the relaxin hormone, musculoskeletal system there will be a kind of expansion. Pelvis expand to accommodate the baby, and also laxity or looseness in the ligaments around the pelvis, and they get lots of conditions called symphysis pubis dysfunction and SPD, and also back pain, and all this hip pain, back pain, pelvic girdle pain. These are very common. Okay, so most of the women will come and tell you, I have back pain, I have muscle pain, and all these symptoms. And they also get carpal tunnel syndrome. So there will be a kind of water retention in the ligaments, and median nerve will get compressed, and they will come with carpal tunnel syndrome. And also lower and upper back pain. Sometimes costochondritis. All these were common. So you should know. And body changes when the baby is becoming big. Muscles, abdominal muscles stretch, and joints, there will be a lumbar lordosis and increased mobility of the joints, painful arcs. All these are the musculoskeletal changes in the body. See, sacroiliac joints will become loosened, and that becomes painful. Okay, and pubis symphysis, there will be a little bit of separation. This can increase after delivery also in the postpartum period. We had a case recently. We had a case of pyogenic sacroiliitis. When the big muscles and the joints become loosened, one woman had an infection it's a urine infection actually, GBS, streptococcus infection, and she had hematological kind of spread into the joints, and this GBS caused a abscess in the sacroiliac joint. And after delivery, because of the muscles, we mobilize her, we position her in different position. This got worse, and she had a subluxation in the sacroiliac joint, and she was not able to walk after delivery. So we had to we were not aware of what as to what could have happened. So we tried all the possible ways. Finally, an MRI showed that there is an abscess and increased fluid level in the sacroiliac joint, and we gave her IV antibiotics, and kind of we gave supportive care. She was not able to walk nearly for 6 months because of the muscular and joint involvement. So these things can also happen in pregnancy. So these knowledge of these physiological changes and anatomical changes were very, very useful for us to treat these patients. So I told you one postpartum diuretic condition. I told you that is very, very rare. These were presented in the research as research article because these were very rare. Okay, so give me a second. Professor Dodampala is calling. Hello, sir. ඉවර වෙන්න යන්නේ තව ස්ලයිඩ් එකයි තියෙන්නේ. Okay. Okay, so these knowledge were very important. So these were rare occasions. You don't have to code these things in kind of in when you kind of answer the questions. All these cases that you showed were life-threatening conditions we saved, life-threatening conditions we were able to handle in our unit. And these were very, very useful, and we had to use the knowledge of physiology, anatomical changes a lot to save the save women's lives. Okay, so give me a second. That is one thing I wanted to stuck una neda. You have any questions up to now? Hello, guys.
Sir, regarding hereditary moles, sir, what kind of symptoms do they get? Like, how do they know it's not an actual pregnancy?
Yeah, you are going to have a early pregnancy complication lecture maybe later. But hereditary moles, when it forms, they usually nowadays, those days, in long time back when we did not have scan machines, they come with fundus mordandates and high blood pressure and exaggerated pregnancy symptoms like vomiting. Nowadays, we have scan. Almost all women get an early pregnancy scan done. When we do a scan, we know it is called snowstorm pattern. Snowstorm pattern. So this is very easily diagnosed by the scan nowadays. Okay.
Okay, sir. Thank you.
Okay. And changes in other organs like uterus will become biggish and it expands. There is a picture in the 10 teacher book. So if it is the 12-weeker, it is at the umbilical level. Sorry, it is at the suprapubic level. It is uterus come to the umbilical level around 20 weeks. So you should know that. And slightly, there is a picture එක බලා ගන්න. As I said, breast will become enlarged and tingling sensation, nipple size will increase, pigmentation will increase. And also, we had a very interesting case again. Since we are a referral center, we get lots of referrals and all the difficult cases were normally transferred to us. So we have to, now this case was a very interesting kind of disease condition. She had normally in pregnancy, breast changes occur. Breast changes occur due to progesterone, estrogens, and prolactin hormones. Very rarely, some women do react very quickly to hypersensitive prolactin receptors. So this is a very rare condition called gestational gigantomastia. Gestational gigantomastia. The breast tissues will become enlarged. And this can happen in pregnancy, postpartum, and even in young adults also, this can happen. So we had to, do all this initial hormone suppression treatment and all, but it didn't continue. She was, because we were not able to do it because she was pregnant. So while she was pregnant, we continued that. We continued the pregnancy, anticipating a delivery around 37 weeks. But this woman, because of one breast was nearly 10 to 12 kilogram size and big one. And because of this, she was immobile in the ward and she had DVT, deep vein thrombosis. And So we had, and still we were managing her. And you can read this, these cases in online. There are, if you Google, you will find out. It is interesting. And finally, she started to, because of the skin that stretched from the breast, she started to form ulcers and candida infections. So finally, we had to perform an emergency mastectomy. And we continued the pregnancy after mastectomy. She delivered a baby, and we did formula feed. This is a very rare case of gestational gigantomastia complicated with DVT. So this had a kind of, we had to actually, when I was a house officer, I managed this patient. I was basically coordinating, and Professor Kaluarchi was managing all these cases. All these life-saving efforts were very kind of, we were able to do this with the knowledge of anatomical physiological changes. So this is actually, we can't finish it in one lecture. You need to read, you need to understand. Whenever you come across a patient, you see what kind of changes, pregnancy hormone changes, what kind of bodily or functional changes that she has, and how it is helping her to kind of continue the pregnancy, how she is coping up. All these things you should kind of interact with the patients and see the managements and understand. Okay, that ends my presentation. If you have any questions, you can always reach out me. Professor Dodampala is waiting. If you have any questions, I can quickly answer. Okay, then I will leave you alone. I think Prof. Dodampala will take you from here. So, okay.
Thank you, sir. Thank you, sir.
Okay, bye-bye.